would like to congratulate the organizers, Dr. Hamad and Dr. Suleiman. This has been an amazing conference. I found it very inspiring listening to all the cases from the different specialties, and I feel really motivated to go back and do clinical work. It's really an amazing meeting, so thank you for that. But over the next few minutes, what I'm going to do is I'm going to give a bit of a different flavor of where we stand with innovation in pediatric neuro-oncology. So it's a bit different from what we have been discussing all this time, because primarily just I'm going to give you an idea of where the field is going and what to expect in the future, and some of the things that we are been doing at Columbia University Medical Center in Pediatric Oncology Department. So the first aspects of innovation update that I want to talk about is, first of all, the precision medicine neuro-oncology, which is a very hot topic for the past 5 or 6 years. So the definition of that by the NIH, as you can see here, is how do we adapt some person's genetics, environment, lifestyle, and specifically for each person's or for the oncology purposes for the patient's specific tumor to prevent or help with their specific disease. So we used to call it up until 5 years ago personalized medicine, but in oncology this has been converted now to precision based on identification of specific targets that we find in the tumors. And this precision approach has 2 aspects on it. One is in prognostication, how we stratify to tailor the treatment intensity, and second, in the actual therapeutics, modifying the treatment accordingly. And I will also touch upon some of the innovative things that we do in brain tumors with drug delivery at Columbia. The important thing is that, as I mentioned yesterday, although the nomenclature of the different histologies in brain tumors appear to be relatively simple before, after 2016 we have a new nomenclature and a new classification which, as perplexed as it sounds, is getting more and more complicated. So we are dealing with approximately 100 different entities in brain tumors if you combine pediatric and adults, and this is because of the genomic changes. So without boring you with details of how we do sequencing of the tumor, just suffice to say that right now is considered standard of care for every patient who has resection for their brain tumor or any solid tumor, that we do sequencing. And obviously, as you can remember, what sequencing is in practical terms is we evaluate all the mutations at the DNA level, and there are various now methodologies that are very cheap and quick and has been routinely incorporated in the medical care in various countries, not only in the United States and Europe, but throughout Asia as well. So this is considered now standard of care, and we do get these results within 2 weeks. So we get what we call whole exome sequencing of the tumors, and there are some variations of that which I don't need to go into details with methylation, and we also do RNA sequencing to thoroughly evaluate the tumors. So how does this impact in real life? Because that's the question. I mean, so these are all nice theories. We see all these various colors with the genomic data, but how does this affect practically what we do? I'll give a first example, ependymomas, which are tumors, typically of the posterior fossa or sometimes supratentorial. And we mentioned yesterday the histology that we knew up until a few years ago, and we even thought that it has some prognostic significance to be anaplastic or cellular. But the reality is that this doesn't matter anymore. We don't rely on histology for ependymomas to make treatment decisions. And this is because we have new methodologies to identify what determines the natural course in the biology of these tumors. For example, in Europe, we examining now what is the role of chemotherapy after radiation therapy for these patients. In the United States, we are evaluating a different question, but primarily with a modification for patients who have residual tumors. We don't need to go through the details. But the most important thing is now, because of all this confusion and controversy about the histological, the prognostication based on histology or molecular profiling, there has been a consensus amongst Europe and the United States that we do realize now that not all ependymomas are the same, and we have divided in 4 major groups. The supratentorial ones, which are the RELA positive, which have a unique molecular profile, and they have very different biology and natural course from the YAP ones. As you can see in the, there you go. The difference here, these are both supratentorial ependymomas, and you can see the difference in prognosis. This is 100% survival with surgery only, who we used to irradiate before with the expected consequences, and the opposite, the RELA positive ones, who now we can go back and do a simple immunohistochemistry that we found that it correlates with a molecular profiling, and these patients need more treatment. Similarly, there are patients with posterior fossa that would do very well with minimal therapy with radiation only, whereas the posterior fossa type A, which also have different cytogenetics, we are failing with every treatment. So that means that the molecular stratification has helped us in ependymoma to at least try to understand what is the expected biology. We are not doing very well with metastatic patients with ependymoma, and we are still trying to figure out what is the best treatment. For young infants, we still use chemotherapy, and we try to incorporate new biological agents, but still we need craniospinal radiation with all its complications for older children. And even when patients relapse, also it's only radiation that works as it stands, but based on the molecular profiling, we are working on targeted therapies, and this is a list of targets we have identified, including immunotherapy, which is, I must admit, is the least developed in neuro-oncology in particular, as opposed to other solid tumors or the adult cancers. So the second example of where all of this molecular profiling has helped us is the case of medulloblastomas, the other posterior fossa tumors. And as traditionally we would use craniospinal radiation with chemotherapy for older children, or chemotherapy with high-dose chemotherapy with stem cell rescue for infants. Now, for the past 8 years or so, the 3 major groups, the group in Heidelberg in Germany, the Toronto for Sick Kids, and St. Jude's, they helped us identify through international collaborations that in fact also medulloblastomas are not all the same. So irrespectively of the clinical characteristics and irrespectively of histology, we have figured out that there are various subtypes with different prognosis, namely the sonic hedgehog, the wind, the group 3 and 4, with different metastases, but also they are pointing us towards identifying areas specifically for their biology that we can target. We have gone even further, and we have studies now with what we call radiogenomics, where you can even, just by looking at MRI, there are correlations with the genomic profiles, and you can identify the various subtypes depending on the MRI features. This gives us is 65 to 70% specific and sensitive. So just by looking at MRIs now, we can say with a good, reasonable prediction what is the genomic landscape of the subgroup of these tumors. And that's why right now, although we have not fully incorporated yet, for example, this is an algorithm of treatment in Europe, where we use traditional chemotherapy still in radiation, but this approach has helped us identify a subgroup of patients who need more intensive therapy, and this is what we're working on right now, both in the United States and in Europe. We also have been fortunate to identify targets that we have drugs for, and although this is an old initial case report, for example, we have found that sonic hedgehog medulloblastomas can respond to specific sonic hedgehog inhibitors like vismodegib. The problem with that is that as we are experimenting with these agents, we do find new toxicity profiles, for example, growth plate injury and transient responses or even development resistance that is very different than the chemotherapy. So the first conclusion is that subgroup identification of pediatric brain tumors has helped with the stratification of possible risk assignment based on the molecular profile beyond the standard clinical characteristics. But we have better news paradoxically for the low-grade gliomas. So we don't cure all the low-grade gliomas. For example, as mentioned yesterday, the hypothalamic ones are at particular risk. We have several lines of chemotherapy that sometimes patients do relapse through it, and we don't like the use of radiation therapy in low-grade gliomas because even for the patients who do survive, there is we know that 20 years or 30 years from the time of diagnosis, we increase their risk for strokes, neurocognitive impairment, and second malignancies. And thankfully, based on, again, the physician-scientist work, we have identified new pathways, for example, the B-Raf Pathway, that it is critical in low-grade gliomas. And we know, for example, that if you have a patient with a B-Raf V600E mutation, this patient has 70% chance of responding on dabrafenib. Dabrafenib is an oral medicine. The toxicity profile has nothing to do with chemotherapy. It's primarily fever, diarrheas in the first week, and then is very well tolerated. And now we are in a bit of a dilemma, all of us in the oncology community, of do we move this drug straight up front as a standard of care in the absence of having long-term data in terms of how this patient, how long do they need the treatment for, and what is the impact on their health if you use it as a chronic disease. This is another example of a MEK inhibitor for low-grade gliomas. Even in a phase 1 study, we get significant responses. And occasionally, we have seen this now in high-grade gliomas. Now, the bad news is that if you take all the brain tumors overall, the percentage of which we find actionable targeted mutation remains extremely low, is in the range of 5 to 6%, which makes this all fancy biology look a bit of a, not false hope, but indicates that we have very, very long way to go to improve things. And so the chances of benefit are small. So what is that we do in Colombia to overcome that? Remember, when we talk about precision therapy and when we talk about cancer pathways, this is in reality what we are dealing with. So the tree of interaction between the different pathways is tremendous. So what we are leaders in at Columbia University Medical Center, having access to incredible department of system biology and bioinformatics, what we do is we don't just sequence the tumors, we use other platforms so that include what happens at the RNA level, at the transcriptome level, and we try to match this with predictive mathematical modeling. So we delineate which pathways are activated if one is on versus another one. And based on that, we create as you can see here, we create a bottle of master regulatory proteins that we need to attack for each patient's tumor. So this has gone beyond DNA sequencing, and we have created a consortium within the United States and Europe where we are using these platforms and the technology to apply it straight to first to mice to make sure that by identifying these master regulatory proteins, whether we can improve therapy. So the other big area that I'm personally involved and I have done a lot of work is in the area of drug delivery for diffuse intrinsic pontine gliomas. As mentioned yesterday, this is the worst cancer that anybody can have, specifically a child, where you're diagnosed with cranial nerve deficits. You see your child deteriorating with neurological devastation month by month, and we use steroids and radiation to prolong life, and unfortunately there is death within 9 months. So there is a desperate need for innovation for the benefit of these patients. So while I was still in London a couple of years ago, and that's one of the major reasons that I moved to Colombia, and I explain this a bit more, is that we, jointly with my colleague from Bristol, Stephen Gill, the professor of neurosurgery, we decided to move the benefit of convection-enhanced delivery instead of using it in patients for Parkinson's and other neurological diseases, to try to do this directly into patients with pontine gliomas. So what convection-enhanced delivery is, that is practically you deliver a drug under constant pressure, which is controlled so that the diffusion of the medicine, as you can see, and here versus here, this is a simple infusion. This is through convection. So you allow the drug to diffuse under gradient pressure within the interstitium, so you achieve much better concentration within the tumor. So we used the technology with catheters that minimize the tissue damage and reduce reflex, and they're permanent, very thin catheters, only 0.6 millimeters. And this technology, with this technology, we use 4 catheters that are connected with a small port behind the ear, and the catheters go straight into the brain stem and allows us to infuse medicine. This is how the port looks like behind the ear. It's very simple, and we can use it for repeated infusions. So that we started doing this with few patients with repeated cycles with direct infusion of the medicine. This is how it looks like, where the medicine is going directly into the brainstem, and we use software that allows for us to determine the exact contribution of the drug from each catheter. And I used to be by the bedside for 12 hours to regulate the infusion rates of each catheter, to monitor for real-time neurological toxicities like facial pulses, weakness, etc., depending on the anatomic location and the infusion rate. And the drug that we used was based on work at Stanford and UCSF, where they, using high-throughput screen for new drugs, were identified for DAPG that histone deacetylase inhibitors are the class of drugs that perhaps can have an effect. And indeed, this is a patient that I had to ask, while still I was in London, for permission from the European medicine authorities to do an exceptional patient circumstances delivery for this patient with panobinostat. And she's 3 years now alive with a direct infusion of panobinostat. So when we did further work we couldn't use the specific drug for various bureaucratic reasons, but we did a small pilot study with carboplatin and sodium valproate, which is also an HDAC inhibitor, and we saw 2 further objective responses out of the 10 patients in the panobinostat trial. We're going to start now at Columbia University Medical Center using even a more innovative device where we use the baclofen pumps for ambulatory treatment directly into the brainstem, and this trial is about to start. What we are also working in the laboratory while we're doing the clinical trials is that the technology that I mentioned earlier about precision therapy, we use in animal models to create a pipeline for drugs that are not chemotherapy for either direct drug delivery or systemic therapy. And the other major area that we are working on is disrupting the blood-brain barrier. So a lot of exciting things are happening, and especially in neuro-oncology, unfortunately, we have very long way to go. And with that, I will stop.